All right, chapter 4. Okay, so this is where there's been a lot of excitement in the new therapies. I haven't been able to talk about a new therapy since a new Pro patch was re-released several years ago. But there are several new Parkinson's therapies just became available this year. So it's very exciting. So chapter 4 of my talk, I actually got stuff to talk about, where normally I don't have a whole lot to talk about. So one of the things I always want to bring up is exercise in treating Parkinson's disease. This is a study. This is a person, how quickly they make movements. This is them on medicine. They move pretty fast. This is them off medicine. They move pretty slow. This is after doing exercise. There's an effective exercise, fairly short-lived, that actually mimics a dose of levodopa. So not only is exercise probably good for you in the long run, it has short-term benefits as well. Now, I talk to patients, they always tell me, yeah, I feel better after exercise. Right afterwards, I'm a little shakier and I'm a little tired, but once I recover, I feel pretty good. So I really try to encourage people to exercise. I can tell you that the healthcare people that I take care of, the doctors and the nurses and the therapists, they exercise like crazy. And the idea is, if we think exercise is good for people with Parkinson's, if you have Parkinson's and you think about people that you know in your age group living in your community, you ought to be in better shape than them. You should be doing more exercise than those, quote, healthy or non-Parkinson's patients. This should become your career, exercise. And it really does work. This is a review called a meta-analysis of all a bunch of different exercise studies. Really, just about any exercise appears to be beneficial. It seems like the more aggressive it is, the better. So a lot of times the control group, and I'll show that first, they do stretching. I think stretching is very important in Parkinson's, especially the shoulders, keeping those shoulders from freezing up. But if you just do stretch, and you don't do something that's a little bit more aggressive, either resistance training, or endurance training, or something else like Pilates, even dance, a variety of things where you really, get some effort. We think that pretty much any exercise is good, as long as you put in the effort. Tai Chi, so this was, in 2012, this was voted the most important paper that came out in Parkinson's. So I still show it. People who did Tai Chi had fewer falls and did better with the Parkinson's than people who did just stretching. The resistance group, they did well too. So if you just stretched, there was 186 falls in that group. People who did Tai Chi, there was only a third of that, or less than a third, about a third of that. So people who do Tai Chi, who were kind of randomized into getting that therapy, did better. So I'm a big proponent again. Tai Chi, yoga, Pilates, dance, all these things. The Parkinson's, we belong to this little network where we try to fund exercise groups in Parkinson's disease. It's very important. So I always like to start off this chapter 4 when I talk about therapies to remember not all therapy is a pill. The exercise therapy is very important. I send any one of my Parkinson's patients who will go for speech therapy and for physical therapy because I think it helps. And pretty much they all tell me it does, unless they don't like their instructor. Say, that instructor was a jerk. They like the instructor and they go, pretty much everyone's happy they went. Caffeine, there was a big study looking at caffeine, or pretty big study looking at caffeine, thinking that people with Parkinson's tend to be sleepy. Let's give them some caffeine. And they were a little bit less sleepy, but it also turned out that their Parkinson's rating score, remember this stuff, that stuff, actually improved with caffeine. So caffeine, we think, may have some neuroprotective effect, we're not sure, but it also seems to have some symptomatic effect. This was 200 milligrams twice a day. Depending on the type of coffee, that's something like 4 cups of coffee a day. It's not good for everyone. There can be heart issues or blood pressure issues, but it's interesting. So the actual medications, there's a variety of different ones. So some of you may be on dopamine agonists. They go by names like pramipexole, ropinirole, retigotine, the new Pro patch, Mirapex, Requip, and then Apokyn, which is an injectable medication. So these are medicines that mimic dopamine. They don't increase the amount of dopamine in your system. And remember, that's what causes a lot of the motor problems in Parkinson's, but these trick the body into thinking there's more dopamine. And they work well, but they have a lot of side effects: nausea, vomiting, sleepiness, dizziness, and also these behavioral disorders. Some people gamble, overspend, they become sex maniacs. I use that term in sort of a funny way, but I've seen fairly tragic results from people having behavioral changes on these medicines. They sound pretty bad, right? Why do we use them? The only reason we use these relatively weak medicines with all these side effects is it delays and reduces the amount of levodopa that we can use. And we know that the more levodopa you're exposed to, the higher your risk of developing dyskinesias, which are the Michael J. Fox type movements, which can be disabling, and also motor fluctuations, which is wearing off. People take levodopa, it lasts for a couple hours, wears off. The longer you can stay on these longer acting, weaker, crummier medicines, the better you can do. So that's the rationale behind it. Not all neurologists subscribe to this. A lot of neurologists don't even bother using these medications. They think that they're weak, they're expensive, why not use the good stuff right away? My philosophy, and when I treat patients, is if I think I can get away with them being on these medicines for a while, I'll try it. But if they start complaining of abnormal behaviors or being way too sleepy, especially if they're driving, we take them off or reduce the dose and put them on the good stuff. So I introduced these because there are some new dopamine agonists that are going to become available, hopefully fairly soon. So apomorphine at this point is used as an injection. It's not used that often. I think I have 3 patients in all my practice who use it. If you wear off suddenly, in other words, your Parkinson's symptoms come back and you're frozen or you're stuck, you can actually give yourself an injection of this stuff. About 10 minutes later, you feel pretty good again. In other countries outside the US, it's actually used as a pump, and people get this infused continuously. They're going to start trials of that therapy in the US hopefully soon. There's also an inhaled form of this drug, so you breathe it in, kicks in about 10 minutes, a little bit maybe less scary than a needle, but needle's pretty simple too. But that's something that may also become very popular. The last movement disorder meeting, which was a couple months ago now, this was the big drug, Synapsis. This is a thin, if you've ever had any of those dissolvable, like Listerine things, you know, breath fresheners, it's a little piece of film that dissolves in your mouth. So this is something that has that apomorphine in it as well, and people did very well with that. It dissolves in their mouth, and I think about 15 minutes later, 40% turned on within 15 minutes, 100% within 30 minutes. We call this rescue therapy. So it's for people who are doing pretty well, but then they, for whatever reason, the medicine wears off and they're trapped and they have a lot of symptoms. They can use this to rescue. So this is pretty exciting. There's other dopamine agonists that are in trials. We're doing two of the trials at our center, hoping to find ones that work better than what we have so far, because the ones that we have so far are kind of just so-so. So then on to the main attraction, which is levodopa. Levodopa is the best medication for Parkinson's disease. Everyone who has Parkinson's is going to be on it at some point. And it comes in a variety of different forms. This is that same chart that I've been showing you. This is improvement of your Parkinson's, that's worsening. And this is a trial that shows, different from those other medicines I showed, this has a really potent, very strong anti-Parkinson's symptom effect. It has some side effects, nausea, vomiting, hallucinations. It also generates fluctuations and dyskinesias, which I talked about a bit before. But generally, if you have Parkinson's, at some point, you're going to be on this stuff because it's the best stuff. So what happens when you've been on it for a while? So the more that you take, and the longer you've been taking it, the higher your risk of fluctuations. So what this shows is the amount of people who don't have a particular problem. So this is wearing off. So this group of people was on the lowest dose of levodopa, which was 400 milligrams a day. It's a pretty low dose. So most people start at 100 milligrams 3 times a day. That's 300 right there. Sometimes I'll go up to 1.5 or 2 pills 3 times a day, so you're already over the 400 level. So it seems like at about 400 to 450 milligrams, the risk of developing this wearing off, the medicine not lasting long enough, and the development of these abnormal movements, the risk goes up. There also was a recent study that found that if you're a woman, if you live in North America, if you're underweight, if you've had it a younger onset and you're more severe in your disease, your risk of these things is higher as well. But, you know, fat men get this too. So all this is just a way of looking at the risk. And it's also one of the reasons why when I talk about some of the other medicines and why we use them, It's to try to reduce the dose and reduce the exposure to this. But if you need this, you got to go on it. Because those of you who are on it know it's like a miracle. It can really reverse most of the features of Parkinson's. So in order to try to even out these fluctuations, there's a couple other medicines I'm just going to mention because some of you may be on them. So Comptan or Stalevo and Tacopone, all the same thing. These medications can prolong how long the levodopa works. It keeps it from being broken down. There's another medication called Tasmar, which is not used quite as often. But the idea, again, the levodopa increases the amount of dopamine in your brain. This stuff, the COMT inhibitors, makes that last even longer by keeping it from being broken down. So what do we have? So has anyone heard of Rytari? Hands? Few? All right, so Rytari, we've been waiting for this for years. This is a big deal. So what it is a capsule. It's shown up there on the top. And inside this capsule there's a powder, which is just carbidopa, levodopa, the same stuff that we get with one hit with just the powder. These little pellets continue to dissolve over the course of time. So if you can look up here, this top graph is how long the medication works. And you can see it kind of goes on. I can't really read that too well. It's like 5 or 6 hours here. But the other stuff is the plain old levodopa or the Stalevo peters out much faster. So this was very exciting, this idea that we could prolong how long the levodopa works. And for those of us who've done research in this, we know that if you can even out the fluctuations, the ups and downs that you take with each individual pill, we think in the long run people can do better. There's some very early studies where they gave levodopa intravenously and showed that some of those complications, the wearing off and the dyskinesias, actually got much, much better. So this was very exciting. So those of you who've tried it, so we've been using it quite a bit. I started out very skeptical because every time some new medication comes out, you get really excited. You know, Stalevo was supposed to do this too, carbidopa, levodopa, and tacopone. But I have to say that the majority of people find this very useful. It's been a bit of a bear. You have to find the right dose, but people get on the right dose, they seem to feel better. So we know that if you give it 3 to 4 times a day, you get less time off, so that's less time with the medicine not working as well, than 5 doses of Sinemet. And the off time is reduced by over an hour over the course of a day. So that's pretty good. So people who are on that, they're taking 3 doses instead of 5, and they're feeling better. And the fewer the doses, the more apt you are to remember to take them, and the less ups and downs that you have. It works better than Stalevo as well. Study that went out longer, 90% of people with advanced Parkinson's disease dosed it either 3 or 4 times a day, and they took a lot more of it because it's long-acting, it's spread out over a longer amount of time, so you need higher doses. So the dose numbers don't necessarily mean a whole lot. So how do we dose it? So there is a table. And so we take all the levodopa that a person is exposed to over the course of a day, we plug it into this table, and we come out with a dose of this new Rytari stuff. I would say about 1 out of 4 times people on that predicted dose like it, which means most of the time we have to adjust it. And usually we need to increase the amount. 60% in the studies needed higher doses than what we give, but some people actually need lower. We dose it every 5 or 6 hours. Some people are dosing every 4 hours. So there's a lot of tinkering that still needs to go on. But I'd say in the long run, most people like it. The major downside is the expense. The stuff is incredibly expensive. There's one guy in our office who's paying for it out of pocket, $2,000 a month. We are getting it covered by insurances. We're getting it covered by Medicare, but it does kind of push you into the donut hole and actually into catastrophic care. You guys probably maybe know more about that than I do. I'm not that well versed in how the insurances work. But in general, we've gotten it covered so people aren't paying a lot out of pocket, but there's other consequences to it. So depending on how much benefit you get for it, it may be worth it, it may not be. But we tend to give out, we have a lot of samples, we give out samples, we try it out, and I have to say the majority of people do like it and do want to stick with it. So it's been really encouraging, a lot more encouraging than I thought it would be. So for me, this is good news. There are a couple side effects. I think people do find a little bit more dizziness from the medication, and in the trials there was a bit more insomnia, a bit more nausea, and a bit more frequent falls. Falls is always tricky. The more active a person is, the more likely they are to fall. So sometimes more falls, although in the long run it's obviously a very bad thing, you don't want to be falling, but sometimes it triggers that a person is more active. So falls are a little bit different. But the dizziness, the nausea, and the insomnia seem to be things that are holding up as side effects that may be worse than the regular old, generic, cheaper stuff. The other big new therapy besides Rytari that came out, something called Duopa. These are trials that I was involved in. This is what people get is it looks like a feeding tube, if you've ever seen a feeding tube, or a peg tube they're called, and you connect to that feeding tube a pump that pumps in levodopa continuously. It's kind of a slurry. On the other end of the tube is an extension tube that goes into the small intestine where the levodopa is absorbed. So the idea is you drip the medication directly over the site where it's going to be absorbed. And we see a pretty big reduction in the fluctuations, the on and off time, and in the dyskinesias. The problem is you got to walk around the tube coming out of your stomach. Not always the best thing. There's a lot of complications to walking around with a tube. You got to flush it, you got to keep it clean. And early on there can be complications, and the tubes need to be replaced. And the pump weighs about a pound when it's filled. So you're walking around with this 1 pound weight slung over your shoulder. So there's a lot of downsides to it, especially early on, but we were very excited to get this released. And in fact, I'm one of the people who goes around training people on how to use it. But because it came out almost the exact same time as Rytari did, I don't have anyone on this. So anyone who was supposed to get this is now getting Rytari. If they fail Rytari, maybe we'll think about this. But at this point, I think because of the complications, it's taken a back seat. And I'm going to talk about some of the other things that are out there. So there's other versions of Comtan that may be more effective, so looking into that. These are things that are in the future. There's an accordion pill, which is fascinating. You take a pill and it opens up like an accordion would open up, and it sits in your stomach, and it dissolves. So one of the problems is the levodopa is only absorbed in some small part of your intestine. This is a pill that stays in your stomach so it doesn't get flushed along and continually releases the medicine. So it's kind of like maybe a better version of Rytari. So the people who make Rytari impacts, they're trying to cash in quick because there's better stuff on the way. I'll skip that one. There's a couple of other ways to work on levodopa. So this was also a big hit at the recent meeting. This is a pump that actually pumps levodopa underneath the skin. So one of the problems with levodopa is it's not very soluble. It's hard to pump in enough. And so this is a way that this company, Neuroderm, has found to pump it in underneath the skin. So this may be a new therapy. It's certainly better than getting a feeding tube placed, although you have to stick these little needles underneath your skin. There also is something called Xenoport, which is a levodopa that's absorbed throughout the GI tract, not just in one small area. And we think that may be a way to get it to last longer as well. There's a bunch of other things, some weird things. There's a device that drips levodopa into your mouth all day long, so you're continuously getting dosed. There's these frequent dosing microtablets. There's a machine that dispenses a dose of levodopa into water that you can drink at particular times. All these little kind of gimmicky things. There's an inhaled levodopa. This is a study that we're doing, where if the medicine seems to wear off, you use an inhaler, you get a hit of levodopa, rescues you from being off. So these things are out there. They're not available in clinics yet, but they're on the way. Sulfinamide is an MAO inhibitor like the rasagiline and selegiline I talked about. It's been approved in Europe. They're looking to approve it here in the US. It may have some benefits over the other ones that are available now. Flattens out those fluctuations so you don't have the ups and downs of on and off, and may also not increase dyskinesias, which is one of the side effects of those medicines. There's a variety of other things. There's a long-acting amantadine. This, again, is in clinical trials. I have patients on this. They like it. I think this is something that has a future. Biotide, this is an istradefylline, or two medicines that work in a novel way. It helps modulate the body's response to levodopa using different pathways. They're in clinical trials. I was involved in the istradefylline trial. I thought that worked very well. The FDA said it wasn't useful, but it is being used in Japan. And I think it does help. But this Biotize chemical is very similar, and so that may be on the market at some point in the future as well. Again, these are things that are not available but in the US but are in trials. Talk a little bit about deep brain stimulation surgery. It's kind of a revolution in care. This is the surgery where they drill 2 holes in your head and they put a wire down into the deep parts of the brain. There's 2 particular targets. One's called the subthalamic nucleus. The other one's called the globus pallidus. These are just regions of the brain that have abnormal activity in Parkinson's, and by using this electric current, somehow, through some magic, makes Parkinson's symptoms a lot better, especially tremor. And it also reduces the amount of dyskinesias that people have. So this is something we do very frequently in our office. One of the recent studies advances on this is that the medication, or that using this therapy can be done fairly early in the disease process. So as soon as someone tells me that the medicines aren't working well enough for them and they're thinking of giving up their hobbies or stopping working, then we can do this fairly early. Looks like we're running out of time, so I will jump ahead. So just briefly, one of the new DBS techniques is to do it while you're asleep. So one of the problems that people have is you have to be awake for part of the DBS surgery, but there's a new way of doing it with MRI, where a person can be asleep the whole time. There's some new devices that are coming out that can help us steer the current in the brain to make it work a bit better. This is something that, I don't know, 4 or 5 people already asked me about. I guess it was in the Baltimore Sun. This is there's a study done at the University of Maryland, UVA, and some sites outside the US, I think Korea and Japan. Korea and somewhere else. So anyway, what they use is MRI and ultrasound to make a small lesion, a small burn within the brain to treat Parkinson's. So this is the exact same type of study that was reported in the Baltimore Sun. This is back in 2014 in a group outside I think it was outside the US, that put people in this machine. They used ultrasound to make the small lesion, and it in some patients temporarily, and other patients more permanently, improve their Parkinson's. The problem is when you make lesions in the brain, if you put them on both sides, they can affect balance and language, and so we really only like to make lesions on one side. So the therapy, the study that's being done at Maryland, I think they're going to enroll 40 patients. You need to have very one-sided Parkinson's disease to even be a candidate, because people are afraid to put lesions on both sides. The other new therapy I'll just mention, since it's out there, is something called droxidopa. It's a medication to treat dizziness in Parkinson's, dizziness that's come from when people get up too quickly and their blood pressure drops. There's a couple other medicines that do this as well. I consider this third line because it's, again, very expensive because it's a new medicine, and there's generics of other medicines that may work just as well. And the other one, which is going to come out soon, is called pimavanserin. This is a medication that's used to target some of the side effects of levodopa, especially illusions and hallucinations, which can be very distressing for caregivers and for patients. And this is supposed to come out soon. There was a study that was being set up to look at it again. The FDA said, no, the data is so good you can release it. But we haven't seen it yet. But the company that makes it, Acadia, is marketing it like crazy, so it's going to be out soon. And just lady who mentioned she was on Exelon, this is a study that showed that Exelon, Aricept, these medications that are used in Alzheimer's disease can be highly effective for memory complaints and some of the side effects from levodopa. And so we use those very frequently in Parkinson's. So I think I'm just going to stop there. I know I zipped through the end of it, but I think we're going to lose the room. Yeah, so